Good afternoon, everyone. My name is Brittany Harris, and I'm the Development and Events Coordinator for NCCS. I want to take this time to say thank you all for joining us today. I know it's a little bit different than our normal in person symposium, and I do miss all of the regular CPAT members so much, but I know that we have this opportunity to bring more people our amazing programming. I want to spend a little time to talk about my own opportunity to work for NCCS and why I came to NCCS. Cancer has affected me personally. I do have cancer on either side of my family, especially my father's side. My grandfather unfortunately passed away from complications from colon cancer. I know that my family experienced a lot of different emotions as well as experiences with his care, both during treatment and after treatment. I know that I saw a lot of gaps and a lot of things that I wish I knew to help bridge the gap between communication. And I know that in my own professional life, I wanted to do something that would help benefit people around me overall. And I happened to come across NCCS, and I've been so incredibly inspired by so many of the things that you guys have all done. And I continue to be amazed by all of the steps you guys have taken. And I can't wait to see you all again and to definitely hear about how you all have grown. And that definitely helps us do better on this end. And I can't wait to see you all again. And please enjoy your day.
Thank you, Brittany, for sharing what motivates you and your work every day and for everything that you do for NCCS. I love that we're sharing with you all a little bit more about the NCCS team working tirelessly behind the scenes to make our programming possible and what motivates and inspires us every day. So, good afternoon, advocates, or good morning, depending on where you live. We're grateful that you're spending another 2 afternoons with us this week to hear from experts and learn how we can improve cancer care. Last week, we heard from thought leaders on the most pressing issues facing cancer survivors. This year, we'll continue those conversations, identify solutions, and take action. This week is Hill Week, and although it'll be a very different Hill experience than we've had in the past, cancer survivors' voices are more important than ever. As we discussed last week, the COVID-19 crisis has exacerbated and highlighted the gaps in care, and now we have the opportunity this week to bring those issues to Capitol Hill. Tomorrow, we'll talk more about our policy issues and asks to congressional offices. Last week, during the Future of Cancer Care panel, 4 leading oncologists had an excellent discussion on the inequities that exist in healthcare. Today, we're going to hear about one step our healthcare system can take to address these disparities. Having a diverse and inclusive medical workforce is key to achieving quality healthcare. But the physician workforce continues to struggle with adequate representation of racial and ethnic minorities, with hematology and oncology lagging behind medicine in general. According to the American Society of Clinical Oncology, only 2.3% of practicing oncologists self-identified as Black or African American, and 5.8% practicing oncologists self-identified as Hispanic. We're pleased to kick off today's agenda by continuing this conversation and identifying solutions with David Scott, Director of the Roswell Park Office of Diversity and Inclusion. Mr. Scott is dedicated to building an increasingly diverse workforce at Roswell Park. Under his leadership, Roswell Park has exceeded both internal and external goals for workplace diversity and inclusion. He's joined by Susan Camacho, Senior Research Specialist at Roswell Park. Her research is focused on the financial toxicity impact on prostate cancer treatment and diagnosis, as well as community outreach for knowledge, health, and screening. Thank you, David and Susan, for joining us today. I'm going to turn it over to you.
Well, first of all, thank you for having us. And we're real proud of the organization that we work for, and think that we have a lot to share with people, and hopefully it opens up a lot of questions at the end where we can have some dialogue, and there'll be some things that we can help each other on. So what I'd like to start with, if we could get the presentation up, that'd be great. And Just to give you a little background of what we'll be discussing today, if you can switch to the next slide, please. A brief history of Roswell Park Comprehensive Cancer Center. Then we'll go into an introduction of the Office of Diversity and Inclusion, and then the fight against health disparities in minority and underserved populations, and then our bench to bedside research at Roswell and how that is an effective method for our research and testing our research. And then Susan will be discussing her research in prostate cancer and the prostate cancer research program. Next slide, please. And just to give you a brief history, Roswell Park was founded in 1898 as the first cancer center in the United States, and it was founded by Dr. Roswell Park. A lot of people don't realize that that's an actual person, and in fact, his great-great-grandson unfortunately just passed away, but he lived right here in Buffalo and was a doctor of philosophy at the Buffalo State College. And he just passed away a few months ago, but his family still lives here in Buffalo. In 1955, Roswell Park created a graduate division of the University of Buffalo, which today offers Master's in Science and PhD programs in cancer sciences. In 1964, Roswell opens one of the nation's first 3 voluntary platelet collection centers. And in 1972, the National Cancer Center names Roswell Park one of 3 comprehensive cancer centers, along with Sloan Kettering and MD Anderson. In 1981, Roswell Park establishes the Familial Ovarian Cancer Registry, which collects DNA and lifestyle information from families with a history of ovarian cancer, and the registry is used for research to prevent the disease. Next slide, please. In 1995, the United States Food and Drug Administration approves the drug Photofrin, developed by Dr. Thomas Dougherty of Roswell Park as a palliative treatment for patients with obstructing esophageal cancers. This is the first photodynamic therapy drug to be FDA approved in the United States. And in 1998, the FDA approves the drug as a treatment for early stage lung cancer. In 2019, one of the things I'm very proud of is that Roswell Park was listed as one of Forbes' best employers for diversity. We were ranked number 67 out of 500 organizations. And in 2019-2020 years, we were ranked in US News and World Reports as one of the best hospitals for cancer care. We were number 14. I can't remember the total number that we were out of, but we were very high up there. And we were also recognized as a high-performing organization for colon and lung cancer as well. Okay, so next slide, please. The Office of Diversity and Inclusion is here to ensure that people understand what diversity means and the many facets of it, and what inclusion means, which is something separate, and the importance of that.
Diversity and inclusion to me is everybody gets a seat at the table, and in the workplace, it's really encouraging and heartwarming that places like Roswell are so diverse and that it's a priority for them.
At Roswell Park, we have people from all parts of the world with different backgrounds, different cultures, different religions, and we have patients that come from all over the world in the same demographics.
I think diversity and inclusion in society is slowly gaining traction. Not all places are as progressive as Roswell, so our goal as a nonprofit in the community is to make sure that we're getting the word out that we're a resource for them, and having the support of a place like Roswell helps us achieve that mission.
For our employees who come from different backgrounds and cultures, We bring our whole selves to the workplace, and it's important to recognize the whole person. Just as with culturally confident care, we look to recognize the whole patient and what's important to them so we're delivering the best care. Roswell Park is very involved in the Western New York community. We look to be involved with every organization, every community that welcomes us. We come in to make sure people have an understanding of what we do here at Roswell Park and why there's a place for them here as an employee and, if need be, as a patient. The outreach is something that's very important to us to get that message across.
So since the Governor Cuomo took office, he has increased minority and women-owned business enterprises spend from 10 to 20, and now the current goal is 30%. What Roswell Park has accomplished in reaching 50% of minority and women business enterprises spend is absolutely remarkable, rarely done, and they deserve to be recognized for that work that they've accomplished.
I'm excited about the work that we've done with the Buffalo Employment and Training Center, for example. We have worked with them and their clients who are very interested in working with Roswell Park Cancer Institute. However, they're unable to articulate their skills on paper. So what we've done is gone in on a monthly basis to work with their clients to assist them with developing resumes that would help them get a foot in the door with the Institute. Not only do members of the BETC have jobs with us now, they're also developing careers. We're also there for our partners when they need our assistance. Hispanic Heritage Council is an organization that we've worked with for many years for employment initiatives, as well as finding businesses to contract with Roswell that are minority and women owned. However, recently, with the tragedy in Puerto Rico, we collaborated with the Hispanic Heritage Council to have a funding drive and supplies drive to send aid to people in Puerto Rico.
Our council, our community, the Hispanic leadership of our community is forever grateful for Roswell Park and for everyone that's joined in this generous and noble effort.
UBEOC is another partnership that we're very proud of. Not only have we worked with them and their students to help them find internship and employment, we've also been able to give back by giving them equipment to allow them to practice the skills that they would need.
Roswell donated a lot for us. We have a clinical space that we opened up about a year ago. And a simple phone call to Roswell resulted in us basically having, I think it's about 3 rooms full of furniture where our students can interact with a host of equipment. So it really has been an incredible thing for us. The fact that without hesitation, we were sent all of this equipment for our clinical space.
I just continue to look forward to working with Roswell Park Cancer Institute. As a leader in diversity, they set the trend for a lot of what we do here, and it's a great partnership.
I hope that the partnership with Roswell continues to grow and flourish because we definitely need them as a resource for our community.
And our partnership with Roswell, while it has gone on for a number of years, I would argue in the past probably 2 to 3 years, has been the most incredible that it has been. For that, I'm very grateful.
Okay, well, that gives you a rundown of our office, but just to give you a little more of the highlights of what we do and expand a little bit more on what we do and why we do it, I'm just going to run through a few things. We collaborate with our talent acquisition department to develop recruitment plans to attract diverse candidates. So we are a part of the recruitment planning process at all levels for every position. So when a position's open, that's one of the things that we look at is where can we go where we have a professional connection, where we can find diverse candidates. We have an internal and external career development program. And part of the reason why we've done that is because when we've participated in job fairs, we've had many people come up to us and say, I've applied to your organization about 50,000 times and you're not hiring me because, and you can fill in that blank with whatever reason people may say. I've heard it all. And one of the things that I found is that people are not able to articulate their skills on paper. They write resumes as if they're writing them for themselves, and they leave out so much information that is important for them to sell their skills on paper. So we actually work with people internally and externally to help them with their resumes. We do classes, we do one-on-ones, and then we do interview services as well. We assist them with mock interviews. And it's in the past year, we've hired 58 people, through that program, and 25 people were promoted within Roswell through that program. Our corporate social responsibility program, hugely important, because if your community is not behind you, they're not going to trust you with their care. So it's definitely important, and we have an understanding of that, and we work with as many community organizations as we can, and we let them know that we're here and available to assist them. And it's been very few times where we've not been able to make an impact. We do have a scholarship program also, where we work with high school and college students who are interested in pursuing a career in the healthcare fields, and that scholarship is open to minority and underserved people who are from underserved backgrounds. We have 7 employee resource groups, which are important for people to be able to bring forth concerns in a constructive manner and bring forth changes within the organization. We have an LGBT group, we have an African American employee group, a Hispanic group, working parents group, which has been really instrumental in bringing forth things such as flexible scheduling, which we used even prior to COVID-19 measures. We have a healthy foods group because with healthy eating comes a healthy lifestyle, et cetera, which is something that we've got to practice what we preach as far as being in cancer care. We have a veterans employee group as well, and a Toastmasters group that our employees participate in. And the Toastmasters group has been very instrumental in helping people with their public speaking skills, which is also important. Working in cancer care, there's a lot of presentations that have to be given, and you have to talk to people, be comfortable talking to people at any given time. We sponsor community-wide events related to diversity. For example, we held a end of Ramadan festival here last year on our campus in the park that we have, and we had over 500 people from the community and employees show up to it, who were not of that faith, but again, it was a way to share in culture and share and why something is important to someone. And that acknowledgement was big in the Muslim community. And what's the first thing that they think of if they have a family member who has cancer? Roswell Park cared enough about us to celebrate us. So, it's definitely something to have those inroads with those different cultures. And that's just one of the events, many events that we've had. We host events, again, celebrating religious observances and celebrating cultures. At African American History Month, we have Hispanic History Month, where we have celebrations, but we also do Irish American History Month, Polish American History Month events that we have. We're truly, truly inclusive with it, where we make sure no one feels left out. In fact, we even put out a bookmark every 6 months with all of the religious holidays and all of the cultural months, the celebratory months that are out there, so that people are aware, and it comes in really handy. And again, we're not having anyone say, well, what about me? So, and we're always open to hear of new things that we can celebrate if necessary. My office also handles investigations into complaints of discrimination, sexual misconduct, and harassment. And that's also, from our patient population as well. What I can say is I only had one discrimination claim from a patient, and it turns out that there was no discrimination, thank God. But we do know that there are issues, and people want to have someone to talk to just in case they are feeling that way. And sometimes in itself, that's enough to help the situation. So when it comes down to diversity and inclusion, we take it very seriously. We look at it holistically. We also work with organizations that work with people with disabilities. We consider diversity of thought as a big, important thing to discuss. My office handles team building training, and the very first thing that people would say to us is, wow, what is the diversity team doing here? And really, that's all about diversity because we communicate differently, we learn differently, and we understand and comprehend information differently. So it's important that we throw that out there. So diversity is a part of everything that we do. And when it comes down to health disparities, that's another factor as well. We know that many minorities stay away from healthcare facilities because they don't feel that they're going to be treated well. They feel that they're going to be treated as if they're a guinea pig. You know, we know the stories from the Tuskegee Institute. We know about Henrietta Lacks. You know, those are stories that people hold on to because they're afraid. So it's important for us as we fight health disparities to make sure we are visible in these communities and they don't see us for the first time when there's a need. Okay, so there's already a friendly face and an environment that they can attach themselves to before they have to come here, before they need us. So, you know, we do a lot of screening events as well, and we combine our screening events with employment events a lot, just so again, we can get the whole family to come in. But we do a lot of screening events for lung cancer, especially with our veterans population, breast cancer, and these screenings are open to anybody, but we do focus on Latina and African American women with the breast cancer. And then prostate cancer is a big focus for us. Again, anyone can come, but you know, we know that African American men are affected, you know, much more so than any other group, you know, actually combined. So, you know, that's a focus that we have, you know, with prostate cancer. So with that being said, you know, a lot of our research is multidisciplinary in approach. Our scientists and clinicians work together in concert and in consult. So that's what we mean by bench to bedside approach. A lot of the protocols and modalities that we come up with are used in our hospital and they're developed right here on our campus. And it has become a standard by which many modern day comprehensive cancer centers are measured. So right now, for example, Roswell has over 350 clinical trials that are currently going on, including, you know, one for a lung cancer vaccine that we're working with Cuba to develop, and that is the Simivax vaccine. I'm going to turn the floor over to Susan, who will talk about, you know, the prostate cancer research that she does and the impact that it's had.
Hi, I work under Dr. Adam Sumlin, who is doing prostate cancer research. And just a couple facts about prostate cancer. It's one of the most common cancers in men. And 1 in every 7 men will receive a prostate cancer diagnosis at some point in their life. Right now there's approximately 3 million men in the U.S. living with prostate cancer, and but the good thing is that men will not usually die of this cancer, and African American men are approximately 70% more likely to die to develop prostate cancer in their lifetime than Caucasian or Hispanic men. And age is definitely a risk factor for prostate cancer. Early detection increases the survival and treatment options. when talking about prostate cancer. Men that are 50 years or older should talk to their doctors about having an annual DRE and PSA testing to help find prostate cancer early enough. And African American men actually should do this same testing at 40, as we've seen that there's that they will develop prostate cancer earlier. And if they do have an abnormal DRE or PSA, they should be talking to their physicians about the treatment options that are available to them. Since it's not clear whether all men need to be treated immediately for prostate cancer. So the need for screening in the African American men is greater for the fact that prostate cancer is diagnosed approximately 3 years earlier than in Caucasian men. And screening early means that they can get better access to what they need as far as medical treatment and such. And their quality of life actually increases in the long term. And the possible reasons behind the differences between African American men and Caucasian men with respect to a diagnosis of prostate cancer is the limited access to healthcare, socioeconomic status, the lack of knowledge, mistrust of medical physicians, and the lack of participation in early detection programs. So what we're finding is that all of these, the last things that I mentioned, are actually true, that we need more outreach to the African American community and to get them to come in and do the screenings so that their quality of life, if they do have that, will be much better in the long run. So what we do also is that we do community outreach to the African American population. And we go into churches and we do screening at sporting events. We also do, do screenings at churches. The Dr. Sumlin that I work with, he actually goes on the radio stations and TV stations and talks about the need for screening and such for the African American population. So for more information on this, we have our website, which is www.roswellpark.org, and our phone number is actually 1-800-ROSWELL.
And before we open up to questions, I wanted to piggyback off of what Brittany had stated. Part of the reason why I'm here is cancer touched me personally, and why it's so important to me. I remember when my father was diagnosed with prostate cancer, we didn't know of it ever existing in our family, but my father caught it early. He was treated very well, and he felt that all of his questions were answered. And that was something that was so important for him. And in his research, he chose to come to Roswell Park for that reason. And after my father, had the prostate cancer, I said, this is where I want to work. So it was my goal. And then a year later, I was able to get the job in the area that I feel I could be most effective. And it's really paid off for me, personally, because not only am I personally fulfilled, but I'm working towards a mission that I really, really believe in. So I can echo Brittany's sentiments. So thank you for sharing that in the beginning. So are there any questions at all?
So thank you very much, David and Susan, for giving us that overview of how Roswell Park is addressing diversity, inclusion, and health disparities. So if our audience has questions, you can use the chat box to ask the questions. We've received a few, and I have a few, so I'll start, and then as we continue to get questions in from our audience, I'll continue posing them. So first I want to talk about, you mentioned several times about trust being so important and people having this trust of the medical system. And so can you talk a little bit more about how the diversity of your workforce then translates to that community trust?
Well, the main thing is I use this example in my training. When people are going to someplace unfamiliar, the first thing that they do is look for something to connect to. And usually it's someone that looks like them, comes from the same culture, religion, things that they can recognize right away. That's important for them. And one of the things that we wanted to make sure of is that people of all ethnic backgrounds were throughout the organization, not just in certain positions. So, people like to see that someone practices their religion, for example, or at least has an understanding. So those are things that's why we have those different celebrations that we have, so people have an understanding of what brings us together as a community. Even though we have differences, our differences are our strength, and there's always a common bond that you can find within those differences that make us all human beings.
Great. So then how does that culturally competent care, if you're talking about, first of all, there's who you see and the people that are on the care team, but then how does that actually, what does culturally competent care look like from the patient perspective when you're talking about decision-making about care? And what kind of training do providers need to ensure that they have the cultural competence to accommodate differences in communication styles and patient preferences with respect to decision-making?
First things first is asking questions, making sure that our clinicians are asking questions, asking people how they want to be treated, asking people, are there any specifics that we need to be, aware of? For example, for our Muslim patients, it's important for them to know what areas in the hospital are facing Mecca for their prayers. Those things don't stop just because they're coming in for treatment. Knowing, that we have, services for Catholic individuals, knowing that we have services for Hindu individuals. When we celebrate those holidays, for example, we post those things around the hospital, so people know that we are open to hearing from them. So you can't put a price tag on listening. That's the most important thing, listening and putting into action.
Do you want to add something, Susan?
Yes, I just want to add to that I think it's really important to, from the patient aspect, is to ask questions of the physicians. Ask them, what different treatments are out there. Get to know, what exactly that you're looking for with questions. I mean, a lot of physicians are more than happy to answer any questions the patients have. And that's really important, is that the patients need to have a lot of knowledge behind them too. And how they're going to be going about, for treatments or testing or whatever. I think that's a really big issue.
Right, and just to piggyback off of that really quickly, that's why when we go out to these events, it's not just for screening, it's for educational purposes. And we give out a lot of literature, and nothing is that we never charge anyone for that information.
So one question from the audience is, what is your approach to training of doctors to foster a better bedside manner? So you talked about asking questions, but what are the other, and then, and also there's differences in communication styles and decision-making styles. So how do you train your doctors to be able to do that?
Well, one of the things is we do talk about, what our expectations are from the doctors. We work with them. We find out and listen to them. What are their frustrations? Where are they having trouble? If you know that you're going to have a difficult time, maybe it'd be best to have someone with you, who can help you understand and comprehend certain aspects that you may be having difficulty with. So making sure we constantly have that conversation ever present in what we do, because the last thing you want to do is upset a patient, because before, when you had the ability to offend someone, they would tell up to 10 people. Now in the age of Twitter, Facebook, that's immediate and it can go around the world. So it's even more important now that people understand that their bedside manner is important, and it's a discussion in every training that we have with our clinicians that they're required to go through.
Great, thank you. Just so you know, we have a lot of questions and I'm going to try to get to all of them, but obviously people are really engaged and appreciate your comments. So one question from one of our audience members is that you mentioned that there are 350 clinical trials being conducted at Roswell Park. Can you speak about the number of minorities participating in these trials and what strategies you use to ensure their participation?
That's the hard part. And we do have some statistics behind some of the research, but we struggle. We're still struggling. I know where we're doing better is with the lung cancer vaccine because of the effects of that in minority populations. With veterans, you have a large minority population there. Smokers, a large minority population there. So in that study, I know that there's about 35% minorities, which is pretty decent. And if breakdown of African American and Latino, it's about evenly split. And then we have some Native American in there too. So I wouldn't be able to give you an answer for each of them, obviously, but we do keep statistics on that for those reasons. We also do with LGBT populations who are part of these clinical trials as well.
And for our research, we have reached out to our local VA group and also Buffalo Medical Group. So we're actually doing a joint study for our financial toxicity with those groups.
So for the lung cancer trial that has such a high representation, did you do special outreach there, or do you think it was just the type of trial? I mean, that's 35% is definitely better than a lot of other clinical trials. So why do you think that one was more successful?
It was a little bit of both, but I think because people understanding the seriousness of lung cancer, and even though they continue to do things that may have helped cause it or exacerbate it, it was a easier draw, if you know what I mean, from that standpoint, and it was an easier sell. So it was a little bit of both, but the outreach, you can never ease up on that, because as soon as you do, that's when you lose the effectiveness of all of your studies.
Okay, great, thank you. So here's another question from the audience. Do you have patient navigation in the Cancer Center and use patient advocates on IRBs and other internal resources? And are patient advocates an integral part of patient care and interactions for support services?
Yes, we do have patient advocates, patient navigators, and then we also have others. We have trained psychologists and psychiatrists on board for our patients as well, where they would have a dedicated person, because that's an automatic life change event. And many people need to be available, need to be ready for the financial impact, the psychological impact, and make sure that they have support around them to get through it, other than just fighting the cancer itself.
Great. And then how can local patient advocates contribute their skills and experience to further this work that you're doing at Roswell Park?
Well, the one thing we realize is that we don't know everybody. We don't know every community group. We are always open. We're never going to turn anybody away. So if we're not in a certain area that we should be, please let us know, and let us know how we can, relate to a certain group if we've never had experience with that group. Make sure that we're being sensitive and not patronizing to the group. So when we do different events, we're making sure that it's authentic and making sure that people know that we're coming from a place of caring, because without patient care, we have nothing else.
So here's a question that we're spending a lot of time on. We actually have a breakout session following this on telehealth. And with the increase in use of telehealth during the pandemic, how are you considering differences in the use of and access to technology and ensuring that everyone can have effective and culturally competent telehealth visits?
I know that that was a challenge with us because what we do is so complicated. We did find, and I know this from being in our command center during the pandemic parts, people who were younger were a lot more open to the um, telemedicine idea and getting information that way and coming prepared with questions than older populations in general. And one of the things that has to be most effective there is your communication. You're going to spend a lot more time in those meetings with people, especially if they're skeptical about just that process alone, a lot more than you would if they were in person. So having that understanding, remaining patient and calm is a key factor there. And if worse comes to worse, people want to come in, we never shut down. We allowed people to come in, but we wanted to give that as an option. So um, that's how we made it through that time period.
So you gave patients a choice if they wanted to do telehealth or come in.
Yes.
Okay. That's great. I think that makes a lot of sense because I think that telehealth is going to be like other aspects of medicine. If we want to personalize it, we really have to look at what makes sense for each patient. And there's no one size fits all. And, while I think it's in general, younger patients are more open to it, there's definitely older patients who've benefited from it and are able to handle the technology. So I think it depends so much on what the particular visit's about, what the patient's capacity is, what kind of support they have to help them with the technology. So I think we're going to have to look at it as an individual decision making, whether to even use telehealth, because there's not going to be a one size fits all.
Exactly.
Okay, I'm going to change gears a little bit and ask you, what do you see? Because we do a lot of policy work and our advocates are going to be going to Capitol Hill this week, or virtually going to Capitol Hill to talk to their members of Congress. They're going to be talking about policies to support cancer patients with cancer care planning and with being able to have additional support when they're going back to work. But we also work on other policy issues, and I'm wondering from your perspective, what do you see are policy changes that need to be made to improve diversity in the clinical workforce? How do we encourage more diversity in the medical workforce?
Well, I know for diversity in the medical workforce or diversity of patient populations or both.
Well, I'm first going to ask you about the workforce, and then I want to ask you what you see as policy changes that need to be made to reduce disparities in outcomes as well.
Okay. I think from policy changes for the workforce, that's a little difficult because I think we do have great EEO policies and we try to create access for people with different backgrounds. But what's most difficult is capturing the interest of people to go into those fields. So catching, people early on in school. I think, STEM programs should be much better, than they are at the elementary school level and at the middle school level, where kids are getting an idea of things. So I think there should be some mandatory exploration of the medical fields, in particular in the schools. I think that's key, and also fostering, those internships at the high school and college level by having grants for that more readily available. I think that would be helpful with that from the getting people in the door of different backgrounds. From the patient standpoint, a lot of it's going to boil down to finances, and more different abilities to share information. I definitely think our government does great work when it comes down to talking about prevention for smoking, for drinking alcohol, those types of things, but they forget about other factors that can be affecting cancer care. The environment, for example. Recently a lot of legislation had been hacked to death. That was helping protect the environment, which in turn would affect people's abilities to prevent cancer, certain cancers. And I don't think people understood the connections there. So from a policy standpoint, I feel those are things that would be able to help environment and finances.
And Susan, I know some of your research is on financial toxicity. So, and we've definitely focused a lot of our policy efforts on the Affordable Care Act, expanding access to insurance and expanding access to Medicaid. Can you talk any more about the role financial toxicity plays in disparities and outcomes, and any changes that need to be made to help reduce financial toxicity?
Sure. Like with certain prostate cancer treatments, sometimes the treatments can be up to like $10,000 a month. I mean, I don't know a lot of people that could afford, these kinds of treatments. So one of our goals is with our research is to make the government more aware that some of these price points are way above people's means, and so they'll forego treatment, which we consider is not an option. And so and you can really see that within the African American population and versus Caucasian, and that you have different insurance programs that say, one insurance will cover, this part of treatment, but this insurance won't cover this part. So, and we're, and so that's another point that we want to, try to stress for the government is that, that this is a real problem and it needs to be addressed.
So, that actually leads me to a question that was asked last week in one of our sessions that we didn't get to, related to financial toxicities. And so I'm going to bring it up today. The question was, are decisions of survivors and families to forego care based on costs respected? They deserve to have information and make decisions. So you mentioned that that's not acceptable. And I mean, I think we all would like people not to have to forego care simply based on cost. But what if they do have the information and make informed decisions and want to do that? That was the question that was raised last week in another session.
So did you want to?
Well, I know that we've had those situations where people made informed decisions that they didn't want to go through something because they didn't feel their quality of life would be any better. So the financial risk was not, that was a factor too, but it was because their quality of life was not going to be great. If their quality of life was still going to be great, they would have spared no expense.
Right.
So I've seen a lot of that when I got pulled into those situations to discuss with a patient what their concerns were. I think it's always going to be difficult because you have some people, even if they can afford it, they would rather just die than deal with any pain. And that's also another factor as well. So, as long as the information's there and they're truly making the choice, we have to respect that. But if it's strictly financial, we try to find other resources to assist them. And that's what our patient advocates and navigators do, and they do well with that.
Thank you. Yeah, that's helpful. So I just want to ask you a little bit about how is the current climate and the social movement that we're going through right now. And I mean, as you mentioned, David, when we talked last week, you're in Buffalo, where one of the, where one of the protesters was pushed by police and was in the hospital with a head injury. So what is different? What will be different about your work going forward, or how is the social movement impacting what you're doing? How are you all adapting to this? What changes do you see in cancer care as a result of this?
Well, I know just from being on the front line that once there's a mistrust with one entity, there's a mistrust with all of them at the same time, because people have suffered the same indignities in healthcare that they have with the police. And it's something that everyone can relate to who are part of these minority groups. And that fear factor comes up again. So again, that's why you've got to constantly be out there, because it has affected us, has affected people's trust in us, it has affected people's willingness to even talk to us. And that's internally as well. So we've had a lot of work that we've had to do to outreach. One of the things that I was talking to my CEO about was, you need to be more visible. You need to talk about this. Our management team needs to talk about this. They can't be afraid. They need to go up to their employees, ask them how they're doing. Our outreach team has to do the same thing. When they're out in the front lines, don't be afraid to have those uncomfortable subjects come up, because it is a part of the total package.
Thank you. I think that's really important. And your point about this suffering some of the same injustices in the healthcare system as in the criminal justice system. So, that leads me to a question. We hear cancer patients of all backgrounds talk about delays in diagnosis, sometimes because they don't feel like their symptoms are taken seriously. But anecdotally, and there may be data on this as well, but we hear that minority patients will say that they feel that even more strongly. So can you talk a little bit about that, about how do we make sure that patients are taken seriously when they have concerns, and that we don't have these injustices in the healthcare system as well?
Well, one of the things I know that we've done from our end, especially through our health disparities and health behavior teams, is we've worked very closely with the women that we've encountered, because they're usually able to work with their men to get them in to discuss whatever issues are going on. And again, education about some of these small symptoms that could lead to something very big. It's been a big factor for us. And again, using other opportunities and being creative to catch people's attention. Again, going to churches, sporting events, although we can't do that right now, but we have been working with the churches still, working, doing things through community organizations, community groups, and just keeping that reminder out there and never backing away from that, because as soon as you turn away, that's when you've lost more people. So,
and to piggyback actually on what David just said, for example, one of the community events that we did, it was probably about 8 months ago, when we went out to one of the community centers. There was actually more women than men at this meeting on prostate cancer. But what they wanted to get the facts, and then they were going to go back out and they were going to talk to their husbands, talk to their brothers, talk to the men. And that's where, the word gets out, and that it helps.
Yeah, well, I think engaging men more in their care and also in advocacy is something that we're very interested in. And we actually have a breakout session on that tomorrow to talk about how do we get more men involved in advocacy. And I do think, getting to the women to have them influence the men in their lives is really important, but how do we engage men as well? And that's definitely something we're looking at. I want to share another question from our audience. And I think this is a great kind of, well, not wrap up, because I have one final question after this, but what is your matrix in determining the success of your diversity efforts? How do you know if you're being effective in your approach?
Okay, for one, for hiring purposes, we look at, how many people are coming in, but also how many people are staying, because diversity means nothing without the inclusion piece. And if you're getting people in and they're leaving, that means that they're not feeling that they're included here. So you've got work to do on the inclusion end and then the education and that piece. So we look at, our statistics, how many people are we hiring? What does that look like compared to our census, in the area, and how people are available. So that's one thing there. From the patient piece, same thing. Where do the patients live? Where are they coming from? Why did they choose here? But also finding out when we know that patients went somewhere else, or if they wound up leaving us to go somewhere else, why did they do that? Same thing. Did we do something, that made them angry? What could we do to turn that around? What should we not be doing, for future situations? We pay attention to social media. We do surveys with people. We do exit interviews for people who leave, and we do exit interviews for patients as well to see how they were treated. Is there anything that we could do better? So, that's how we determine if we're being successful or not. If people had walked away with a satisfactory experience, and we look at the numbers, to make sure it's in line with what's appropriate for the area.
Great, thank you. So my final question is, I like to ask all of the people we've interviewed for our symposium and our podcast and our webcast about a silver lining. One of our speakers last week said that the pandemic was really like ripping the Band-Aid off the health disparities that we all know are there, but now it's bringing it out into the light to see even more clearly. So what are the silver linings in terms of what this pandemic and then also the social justice movement are inspiring us to do, or the conversations we need to have, or the actions we need to take, that maybe these kind of confluence of issues at this current time can help us really propel us into action to do right now?
Okay. Just to preface my answer, you asked the right person, because my boss even calls me rainbows, unicorns, and butterflies. Because I'm always finding the silver lining in everything, because there always is one. And this one, in my opinion, we have people's attention. People are talking. People are talking about health, and people are talking about social unrest. And in most cases, people are empathetic or sympathetic and open and willing to try, something from the health standpoint. People who were not, really concerned about health before really are now. When it came down to something so deadly as COVID-19, which could kill people very quickly, it really opened people's eyes about health. Our phone calls have gone through the roof, especially from our cancer patients, but from even people who are not cancer patients, just trying to find information on testing, and people understanding the importance of testing. They're watching the news, they're understanding what the symptoms are. So we use that to switch the conversation to cancer. And our tagline recently has been, cancer doesn't stop, and even during a pandemic. So that silver lining is there. It's opened people's eyes. From the social justice, I can't tell you how many phone calls I've received. And just as I stated before, I received phone calls from people wanting to do more, to help with social injustice. What can they do to be an ally? I've been pulled by media, I've been pulled by politicians and our leadership internally whereas they may not have understood the significance of it before. They're seeing it before their very eyes now. So that's the silver lining from my standpoint. I don't know.
Yeah, that's
Thank you. I love that rainbows, unicorns, and butterflies. That's awesome.
I wear it well.
That's great. And I love the silver lining there. And you're right, there always is one. So thank you both, David and Susan, for an informative and thoughtful discussion on addressing equity, diversion, and inclusion in healthcare. We look forward to continuing these conversations and to working to make cancer care better for everyone.
Thank you.
So, thank you. Thank you very much. So now we're at the point of our day where you get to choose your own adventure and identify a breakout session that's right for you. We have 3 excellent sessions today, and I'm sure many of you would be interested in participating in more than one. Remember that the sessions are recorded and are uploaded to our website each day. You can go to the on-demand tab for the microsite for the symposium to find the on-demand presentations. So now click on the button on your screen to join the breakout session of your choice. And don't forget to ask questions using the chat feature and to reach out if you have any technology issues. We're so glad you're here and spending part of your day with us. Thank you.